Can you guys see my screen?
Yes.
All right. Well, thank you all for giving me the opportunity to talk. I guess I've been here 4 to 5, well, not even 5 months, but um, so my name is Lee Cummings. I'm a transplant surgeon with focus on abdominal transplant and hepatic biliary surgery. And Dr. Parrish asked me to give a talk. I think he was asked to give the talk, and so he passed it on to me as a new doc. So today I'll try to talk about kidney transplantation in general and also focus at the end a little bit on the complications, which I think may be useful to you as a urology team. And so I understand the audience is, I can see the residents and attendings, or who's in the audience primarily?
Mostly residents, but we have some attendings.
Okay. All
Perfect
right.
time. They test us on the boards all the time about this stuff. And
Yeah. Yeah. So the talk won't be, it'll be some of the things that I think you need. Um, we won't get too much into the weeds and certain things, but some of it might be nightmares from medical school. Okay, so I have no relevant conflict of interest. Like I said before, we'll go over a little bit about the history. We'll talk about immunology and immunologic considerations, which, as you all know, are part of the backbone of what we do in transplant. We'll talk a little about allocation, which has been in the news of late. We'll talk about the process for referral to listing. We'll talk a little bit about donor selection. We'll talk about some of the surgical procedures, both living donor procedures, deceased donor procedures, and the actual surgery, the transplant procedures. And then at the end, we'll wrap it up and talk about complications, uh, both intra-op, post-op, and delayed post-op. So the first recorded transplant, if you want to call it a transplant, occurred within the third decade after Christ, was performed by these two really famous Christian brothers who initially performed the transplant between an Ethiopian individual and a man with an ulcerated leg. Now, whether or not this is actually true or based on science, it certainly has been a part of many classical paintings and is credited as a first transplant. The first, however, modern advance in transplant really was performed by Dr. Eric Ullman, in Vienna. He initially experimented between auto transplants in dogs, in between the native position and the neck. And then ultimately, he did some transplants in between pigs and dogs, albeit technically he could do the operations, but they didn't really have much long-term success. This gentleman, who you may or may not know, is Sir Alexis Carrel. He devised the first modern vascular anastomosis, the full quadrant technique, which we still use today, but in many cases, whether it be cardiac or vascular surgery. And for this, he won the Nobel Peace Prize. However, he has been quoted as saying in 1914 that we've already shown we can do transplants, the technical ability to do the transplant. However, the primary limitation, and I'm paraphrasing here, being the lack of advances in immunosuppression therapy. Dr. Jaboulet, who's famous for many things, but one of the things he did was in 1906, he performed the first xenotransplant in between sheep and dogs, albeit unsuccessfully, again, utilizing the Carrel vascular anastomosis, which was yet to be published. Then in Missouri in 1901, there were some experimental models for head and other organ transplants, albeit unsuccessful. But these are some of the early attempts at transplantation. Then came the war in World War I. And shortly thereafter, there was, at least during this time, a limited research into transplantation. In 1925, however, Dr. Emil showed at least the first true modern understanding of rejection. He was able to show in successful skin grafts in between mothers and their children that the initial graft lasted 10 days and subsequent grafts failed sooner. And this is one of the first scientific models that showed or gave us an understanding about acquired immunity. Then Dr. Voronoi in 1933 performed the first technically successful kidney transplant in a human, again, food failure results. So you can see transplantation has been sort of like many fields of surgery has been marked by pioneers really pushing the boundaries with poor success. But ultimately, we were successful. Then came World War II, and there wasn't much activity once more, understandably, given the large scale of that war. But then in 1954, we had two twin brothers, one of whom had kidney disease and the other did not. And this is credited as the first successful kidney transplant. Again, technically successful, but the reason why it was successful is because the transplant was between twin brothers. And so there was no need for immunosuppression. So although we had the first transplant that was successful, and it was a long-term success, it wasn't really possible to extrapolate that to other patients. So for quite a long time, transplants were being done uh, with immunosuppression based on prednisone and 6-month captopril, but it wasn't until the late 1980s, and we'll get into that, where transplant really took off because of the advances in immunosuppression. Dr. Medawar won a Nobel Peace Prize in 1960 for actually showing how. So he expanded on Dr. Emil's work and was able to describe the pathophysiology of rejection and acquired immune tolerance, for which he won the Nobel Peace Prize. But like I said before, Dr. Murray and his team performed the first successful kidney transplant, and then Dr. Starzl performed the first liver transplant in 1963. And I think we really have to take a step back to think about what these guys are doing, particularly Dr. Starzl. I mean, he was run out of different hospitals for doing experimental surgery, but he really not only um, perfected a liver transplant at a time when there was no immunosuppression, he also was um, integral in the development of the modern immunosuppressive drugs that we use today. Prograf, which was he studied as FK506 initially. So taking a step forward, I think another important thing that you may want to or need to know about is organ allocation. So, I think over the last, 5, 6 years, maybe it's gotten a black eye for the problems it has, but it has truly been the blueprint by which organ allocation is done, not just in the United States, but all across the world. So it's essentially a company, not a company, but it's an organization whose main job is to police the organ transplant system. So it has created, and in the old days, there were people calling each individual hospital with organ offers, and they created in the late 1990s a sort of a nationalized computer system that's running 24/7, 24 hours a day, that allows us to have a connection between the donor hospitals with all the different centers, and then that's how the system works. It's policed by the OPTN, which is a contracted company with the HRSA. Now, this is probably going to some of the functions of OPTN and UNOS are being sort of farmed out and are being reformed, I think. And so I think this is where we're going to see a lot of change in the future. Some of it's already happening, and we shall see how it goes. But this is how organ allocation is essentially run within the United States by these two organizations. Like I said before, there are major changes coming. A lot of it is unknown as to what's going to happen, and the details are to follow. So, if you think about transplant, I mentioned before, you know, one of the main things that we have to consider in transplant that we don't have to consider with the general urological procedure or the general cardiac procedure or the general surgical procedure is immunosuppression. We're taking an organ from one person and put it in somebody else, most commonly not related. And so we have to give immunosuppression to prevent rejection. So, who is responsible for rejection? Well, there are the T and B lymphocytes, which recognize foreign antigens on these new organs and then cause an immune response. So typically, you put a kidney in, you do the artery in the vein, and as soon as you unclamp, there are cells from that organ being shed into the bloodstream. They're then picking up by APCs, which are dendritic cells, macrophages, and B lymphocytes. They then take them back to the to the lymph nodes, and then you get expansion of B and T cell clones, and ultimately you get antibodies and or effector T cells attacking the organ. So this happens right from the beginning. Eventually, we give things like thymoglobulin, which we'll go over, and ultimately, once you get through that initial phase, those effector T cells and B cells go into storage while you're in a milieu of while things are quiet. But because of these memory cells, rejection can happen at any time, often when patients stop taking the medications, or sometimes when there are other things going on, like infections, for instance, that can ramp up the immune system. So if you think about the steps in the immune response, we went over them first. You get the foreign antigens, and then T cells get activated, and then you get the effectors B cells and T cells. Again, this is schematic representation of what happens. One T cell clone then proliferates into many million cells or many million clones, and then you get the reaction to the organ. So if you take a look at these two triangles on one side and on the left side, the right side shows the steps of the immune response, and the left side is immunosuppression. So ideally, if you think about the immune response, whenever we do a transplant, we don't currently have anything that will prevent recognition. Rather, everything we do in transplant to prevent rejection occurs after recognition. So we try to prevent stimulation. We try to prevent cytokine proliferation. We try to prevent secretion of B cells. But we don't really have anything that can prevent recognition. And so all our agents work below, but we don't really have anything that can really affect above. And if and when we get to that point, then maybe we can get to tolerance, which is when things will really be a game changer. So if you think about the immunosuppressive agents, we talked about transplants. So we talked about the fact that that first kidney transplant was done in 1954 at a time when we had nothing other than steroids. So it wasn't until in the late 1950s when we started having development of azathioprine and its derivatives, which some of these agents are still used today, for instance, with things like Crohn's disease. But this was sort of the beginning of what we had to prevent rejection. And they all function by inhibiting cell division and nucleotide metabolism in those rapidly dividing cells, which are the B cells and the T cells. That's also why they have other adverse symptoms, similar to what we see with chemotherapy. So Dr. Milstein really was a pioneer. He did a lot of his work in Argentina. He was from the UK. And he was able to first develop the first monoclonal antibody, which is integral to transplant. We use it now for other things like in cancer and what have you. But it really was developed to initially help with preventing rejection. So as you can see, we have a long laundry list of immunosuppressions on the left side. Started off in the 1960s with steroids, like I mentioned before, and then all the way to belatacept, which is sort of the newest thing that we've had. And if you think about it, that's 15 years old now, but that's the newest thing that we have in transplant. The difference between that's a medication that can be given instead of Prograf and cyclosporin. So it's a once a month injection that the patients go to. It's obviously a little easier for compliance because they're going to an infusion center and getting an infusion. Currently primarily used for kidney transplants. If patients fail this therapy, they still go back to Prograf. But the advantage is that it doesn't have some of the long-term deleterious effects of cyclosporin and Prograf that they have on kidneys. So if you think about it, the main drug that we give to prevent rejection, one of its main side effects is that it causes chronic long-term loss of kidney function. And so that's one of the barriers that we have to struggle with daily. So if you think about immunosuppression, we put it into sort of two classes. On the right side is induction. So this is what we give at the beginning of the right after the transplant or during the transplant to help prevent rejection for a period of time. And then on the left side is sort of a more maintenance immunosuppression that we give them that they take every day as long as the graft is functioning. And these are the things that many of you in this room have seen when you're on our service. They take a mixture of tacrolimus, amyloidotic, rapamycin, azathioprine, and these are the class of drugs that are second-line agents nowadays because of a decreased efficacy as compared to tacrolimus. So this slide is a little busy, but what I'm trying to show is that this is a lymphocyte showing all the different levels of his inner functioning as it pertains to activation and proliferation. So if you think about immunosuppression, all these different drugs that we can give, whether it be steroids or belatacept here or thymol here or Prograf or cyclosporin here, they're all attempting to affect the immune system in different areas. So you ask, why do we give so many different drugs? Is because no one drug alone can really prevent rejection. Rather, we use different drugs, all of which have a different effect on different parts of the cell and the cell cycle to help prevent things like stimulation, proliferation, and then immune cell, whether it be antibody producing plasma cells or if it's effector T cells function. So again, we won't go over this too much. This is just showing the different levels of the cell cycle with nucleotide and DNA synthesis, which is how all these drugs work. Again, busy slide, just meant to show you again that we're using different things that work in different ways that collectively help us prevent rejection. So, as I mentioned before, all the drugs that we give all affect either co-stimulation or proliferation, meaning what I mean when I say co-stimulation. Going back to this slide quickly, when the APC brings the antigen to the T cell, it binds to the T cell receptor over here, that activates the T cell. But you also have co-stimulatory molecules like CTLA4 and CD40 ligand, which is where belatacept works. So they are working different ways to try to prevent rejection. So this is how these drugs work. And as I mentioned before, none of these drugs affect recognition. If we can affect recognition, that's a holy grail of transplantation. Then we can give it out like candy. So if you think about rejection, the different phases of rejection, hyperacute rejection, I think we've all learned about in medical school, which is where you have preformed antibodies that cause immediate failure of the graft as you perfuse. This we rarely seen. As an example, I've never seen this. This is largely in part because we have a very, not just us, but all transplant centers have a very functional HLA lab, which are able to detect these preformed antibodies. And so if somebody has preformed antibodies, they're going to have a positive T cell and B cell cross-match, and so they don't get the transplant. So we don't see that anymore. What we do see is acute rejection. So usually it's occurring, after they have the transplant, after they get out of the hospital. If, for instance, they're not taking their meds, or if they have a drug interaction and they have a low Prograf level, as an example. But as some of you on our servers know, sometimes it does happen early on. And so even though acute tubular injury or ATN is the most common reason why we have delayed graft function, there are times where we're going to have early rejection. And that's why, for instance, we do a biopsy, or sometimes we inject donor-specific antibodies on the kidney world and the liver world. Sometimes we do a biopsy if the bilirubin's peaking, things are not looking like they should. Chronic rejection is much more delayed. If you think about liver, the chance of you losing a liver graft from chronic rejection is 2 to 4%. So if somebody takes some medications, it is likely they will die with a functioning graft, assuming they don't have any other complications. Whereas with kidney transplant, we know that most patients lose their graft from chronic rejection, typically around 8 to 12 years for deceased donors. And if you think about living donors, sometimes you can extend that to 15 to 20 years. But inevitably, most people eventually lose their graft from chronic injury or chronic cellular rejection or chronic allograft nephropathy. And you can see here, again, a lot of this is based on the blood vessels. So, you have recognition of the organ has been foreign, and then you have attacking of the tubules, glomeruli, and also the blood vessels. So if you think about complications, we talked about early rejection. We also have, so in terms of rejection, it usually presents with AKI. So they have a bump in the creatinine, they come in, they get a biopsy, you see rejection, then you treat them. Typically with steroids, that's the first line treatment for rejection. However, second line treatment for rejection, or if it's severe. So when we think about, if you think about kidney transplant, the rejection is graded based on what we call a Banff criteria. So 1A, 1B, 2A, 2B, and 3A, and 3B. So for 1 and 1A or borderline rejection, a lot of times we do that, we treat that with steroids. However, as you get more severe forms of rejection, particularly if you get vascular rejection, which is type 2B or 3, then you start thinking about giving thymoglobulin to prevent rejection. And then over time, at least in kidneys, you get chronic allograft nephropathy and instances of fibrosis that we talked about earlier. So the next thing I want to briefly talk about is donors. So obviously there are two groups of donors. largely. There's living donors and deceased donors. And notice I talk about pigs here. I think, as you may or may not know, this is sort of where this is the future of transplant, I think. There's some good studies happening right now. I know in recently there's been some bad press with a couple heart patients and a couple kidney patients who've had these xenotransplants that haven't gone as well as you would expect. But there's some real good science now being done at University of Alabama and NYU, where they're really going through a stepwise process to really make this in a rigorous scientific model to be able to allow us to get to the next phase, which is probably a pig transplant. So we're sort of limited to human transplants right now. I don't think pig transplants will ever entirely take over human transplants, but a lot of patients die every day waiting for a transplant. And so this would be a useful adjunct as we can help more patients. So living donors are where, so living donor kidney transplant, I would say, is the gold standard of kidney transplant, meaning these patients, for a suitably chosen living donor, this is the best kidney that a patient on dialysis can get, meaning they have immediate graft function in most cases. It's a scheduled procedure. The rates of rejection are low and they last longer. So a standard living donor, depending on what program you're at, but it is well recognized that living donors do better. So in my last program, for instance, the deceased donors last somewhere between 8 to 12 years, and living donors can last up to 20 years. And that's what we see generally across the board. They just do better. Some of it is obviously biased based on the fact that we're choosing a totally healthy patient and getting a healthy kidney, as opposed to deceased owners where there's certainly some variables that we can't control. So you're not exactly comparing apples to apples, but in general, living donors do better. So they have to come forward without coercion, right? They have to be healthy. They have to have normal kidney function. They have to have no real medical history of kidney problems, and they should not really have excessive family history of kidney problems. Now, it is common that these people are related to somebody on dialysis, but we really don't want to be taking a kidney from somebody whose brother, sister, mom, auntie all had kidney disease, right? We want to select out those who have a limited family history of kidney problems. We typically do ABO compatible transplants, so always a universal donor, and they can give to any recipient, whereas AB is a universal recipient, they can give from any donor. And for instance, there are some incompatible transplants. So O can give to A as an example, right? And A can give to AB and B can give to AB. But generally, we try to make sure it's compatible. There are certain exclusion criteria, like I mentioned before. No major systemic diseases. They have to get a CAT scan because we have to know the anatomy. Obviously, if they have one kidney, which happens from time to time, we're not going to take their one kidney. Partial kidneys, we generally don't use either. They have to go through a rigorous psychiatric evaluation, usually a social worker. If we have concern that there's more psychiatric pathology, sometimes they have this psychiatry. And then they go to medical review, just like we do for any person looking for a transplant.
What's the current consensus if the donor has kidney stones?
Typically, if they're small, like tiny kidney stones in the kidney, that's not a problem. That's not really a problem. If they're a stone former, that may be a problem, but small, tiny kidney stones are not really a contraindication to donation. And as you may or may know, there's some centers that are a lot more aggressive than others, right? So if you think about a donor, we're operating on somebody who's totally normal, right? The only thing we can do philosophically is harm them, right? So we want to be very judicious, but kidney stones in themselves is not a reason why they can't donate. Now, generally, in the old days, living donor nephrectomies were done primarily through open incisions. But thanks to the work largely by urologists, who obviously operate on kidneys a lot more than we do, who have been doing minimally invasive nephrectomies and robotic procedures on kidneys much longer than transplant surgeons, we've sort of also now delved into this arena. And so in the 1990s, the surgeons in Maryland and Hopkins, Dr. Ratner, who was a transplant surgeon, worked with the urologists there to learn this technique. And then from there, it sort of exploded across all transplant programs. So most living donors now are done in a minimally invasive fashion. Sometimes it's hand assist, most times it's not. Sometimes it's single incision, laparoscopic techniques, and in some cases it's robotic. Generally, we try to coordinate the operation with the donor procedure. So we try to do it the same day in the adjoining rooms. There are times where it has to be staggered if there's no room. So the donor goes, then you put the kidney in ice, and then the recipient goes. In most cases, we do it in a staggered fashion. Certainly, there are times when it's a paired exchange. That's happening more and more now, where you procure a kidney here and it flies off to sometimes across the city or other times across the country, where it gets transplanted in other places. So the position you guys know very well. It's generally in the left lateral position if we take in the left kidney. Generally, we take the left kidney as opposed to the right if anatomy is equal because of the longer left renal vein to give colleagues in the recipient operation a little easier um, procedure. The port placement varies from surgeon to surgeon. This is how the traditional laparoscopic technique goes. Um, but the steps of the procedure are the same. So for instance, when I do a robotic procedure, I use a small mini 5 centimeter port here, just medial to the ACES. And then we have 1, 2, 3 ports along the lateral edge of the rectus. Whereas others, if they're doing a purely laparoscopic procedure, they may have a port here at the umbilicus, they may have a hand port up here, and a few other 5 millimeter ports or 12 millimeter ports scattered around the abdomen. However, the procedure is the same. The first thing we do is that we take down the left or the right colon along the white line of Tolt. We then expose out uh, the renal vein, divide and clip the adrenal veins and the gonadal veins. Uh, the ureter comes last. We then typically flip the kidney. We dissect out the renal artery, and then we staple and cut the ureter, followed by the artery and the vein. We then put the kidney in cold preservation solution. We flush out all the blood, and we then hand it off to the recipient surgeon. When it comes to deceased donors, this is what you guys probably don't see. The process is very different. It's a big open incision, totally opposite of laparoscopic. We generally cannulate the aorta. We dissect out the various vessels going to the liver and pancreas while the heart surgeons are working in the chest. We then have a coordinated procedure where we flush the body with preservation solution after clamping the aorta, and then we take the thoracic organs, followed by the liver and the pancreas, and eventually we get to the kidneys, where we then generally most, at least transplant trained surgeons, take out the bilateral kidneys en bloc and then split them on the back table. But I have worked with urologists in the past who, when I was back in Missouri, where they would take out each kidney individually. Do you guys get exposure to donor procedures?
Only on transplant when as an intern.
But how about like deceased donors? Do you ever go out and do deceased donors?
Only on transplant.
Yeah.
Question, Dr. Cummings, what if we're doing a living donor,
Yeah.
what's the minimum length on the artery that a transplant surgeon would want?
As long as we can get.
Okay.
Right.
So I mean, usually we get it when we staple the artery. We're not getting a patch of aorta, but we're stapling it right at the takeoff. We use mechanized staplers that either have 2 or 3 rows, limiting the amount of rows we have. So we want as many millimeters as we can. But it's not uncommon to, for instance, if you have an early bifurcation of the renal artery, that you might get the artery either millimeters from that bifurcation, or at times, if it's really close, if the bifurcation is within 5 millimeters of the aorta, for instance, we may end up getting 2 arteries that we have to put together or do 2 separate anastomosis. That's not uncommon. But as long as we can get. I've had the unfortunate task of having to transplant kidneys with almost no artery, just barely out of the hilum, given vascular injury, but we don't like doing that routinely. Good question. So, sorry. So like I said before, we generally take the kidney out and we flush the preservation solution, at least in living donors, and then we hand it off to the recipient surgeon. So one of the things I think as really one of the real areas of transplant where there has been and is undergoing a lot of changes in how we preserve organs. So I'm sure you've heard about, kidneys being in ice or being in a cooler for how many period of time and then we put them in. Whereas nowadays, there has been a large shift towards pumping organs because pumping organs, whether it be with cold preservation solution or with blood, allows organs to remain viable for a longer period of time, and there is improvement in early graft function. So, for instance, kidneys. So, traditionally, I'm sure people you've heard, and it's still, we want to transplant kidneys within 24 hours, but you know, there are many programs where kidneys are routinely put in within 36 to 48 hours. Particularly those kidneys have been on pump, because when you pump the organ with the cold preservation solution, that does allow for amelioration of early delayed graft function. Do you guys know what delayed graft function is?
We're gonna have them.
Yeah, so delayed graft function is where somebody gets a kidney and they're still on dialysis after, or they still require dialysis within that first week. So that's very common, right? And historically, one of the many reasons why that happened is because of prolonged cold ischemia time. So one of the reasons why the kidneys from living donors work right away is that we're putting them in within an hour or two after they come out of the donor body. So very short cold ischemia time. Whereas with deceased donors, it is quite common that the earliest we can ever get a deceased donor in because of some of the logistics is within 12 to 18 hours. So, but with pumping, you can routinely pump kidneys overnight. So, for instance, in my practice, for instance, I haven't done a kidney at night by choice in a long time because we can pump organs. Because we know if you pump them, they can remain viable and they can do very well after. And this is how things are done typically in many centers across the country.
Dr. Cummings, what's the, for, you were talking about the living donors?
Yeah.
Is there still a gold standard for that, for timeline? You said 1 to 2 hours, but is there a time
Yeah.
that, where you start losing function?
You don't really, so ideally, so traditionally, most living donor operations happens in a staggered manner, meaning the donor operations in one room, the recipient operations in another room, typically adjoining. So you take the kidney out. So then the donor goes to the operating room within an hour. The recipient goes to the operating room. We do this on a Wednesday, and so by the time Dr. Paramesh or myself or Dr. Tula takes the kidney out, the recipient surgeon already has the recipient open with the vessels exposed, so we can minimize that cold ischemia time. So ideally, that's what we want within an hour or two. But like I mentioned earlier in the talk, we're doing a lot more paired exchange across the country right now. So in my last job, half of the kidneys were paired exchange. So it was routine for the kidney to be, and we were doing about 120 living donors a year. It was routine for the kidney to be taken out, put on ice, and then sent to Milwaukee or New York or DC or California or somewhere else in Florida. And so obviously there's travel time there, right? And
Yeah.
so in most cases, when you had those paired exchanges, you weren't getting them within, if you're lucky, within 12 hours. So there's no real rule that you have to get it within a certain period of time. There's no real loss of function if it's somewhere between 1 to 12 hours. The difference is when it's really short, they have immediate function. Those are the ones coming out of the vacuum making liters of urine, whereas the ones that are longer, they take a while for the kid to wake up. But even in those situations, they still often don't require dialysis like the deceased owners. Does that make sense?
Yep.
Yeah. So, and coming along the pike, we're probably gonna have, whereas we have blood pumps to liver, so you guys might have seen in the news, but we can routinely pump livers now with blood and keep it on pump for 24 hours and put it in the next day. There's some initial work being done by at least this company based in Indiana on the blood pump for kidneys, which I think will be very helpful for us to also not just improve the logistics, but improve early and prolonged graft function of these kidneys. So if you think about the transplant evaluation, one of the things that sometimes people who are not involved with the process ask questions like, where do we get this patient? Because sometimes, the kidney patients are a group of patients who, sadly have a difficult life. They've been in dialysis for years. Many times they have lack of access to care. And sometimes they come in and they look like they don't really know what's going on. But believe it or not, those patients have to go through a pretty rigorous process to get to that point, right? So this picture shows you what they have to go through. So the transplant evaluation process is a multi specialty, uh, uh, a true team evaluation, not just the surgeon, but also the nephrologist, the social worker, the financial coordinator, the coordinators. They have to go, the referring nephrologists, they have to go through all of these different steps and be evaluated by these different people. They ultimately, if we deem them an initial candidate for evaluation, they come in, they see the surgeon, they see the nephrologist, they have various, cardiac pulmonary testing, they get assessments of the vasculature because we have to be able to study kidney into. But of course, we also have to assess for malignancy. Why do we have to do that? Well, we mentioned before immunosuppression. So one of the problems or side effects of immunosuppression is the increased risk for cancers, not just de novo cancers, but the chance that a cancer they already have will progress. And so we have to do a pretty broad assessment for cancer, whether it be skin evaluations to colonoscopies, the G1 evaluations, but also a key component of our evaluation is looking for and treating urologic cancers. So that's where you guys come in. We're talking about bladder cancers, we're talking about renal cell cancers, we're talking about prostate cancer. So if you think about not just cancers, but the urologic function is also integral to what we do, right? We're sewing a kidney in. Certainly the blood vessel part is the easy part, but we also then have to sew it to a bladder. So we have to make sure the bladder has function, it has enough capacity. Does it empty properly? If it does empty, is there a distal obstruction from the urethra, as an example? So all these different things we have to look at as we assess patients for transplant. One of the problems that we see is that a lot of these patients haven't made urine in 5, 6, 7, 8, 9, 10 years sometimes. And so they have a dry bladder that hasn't seen urine in a long time. Or it may be colonized by bacteria and it may not function well. So a key part of our evaluation is get an ultrasound, we make sure there's no anatomic issues, we get a CAT scan. Again, looking for vascular calcifications, but we are also able to look at the bladder and the kidneys. A lot of these patients have acquired cystic disease and cancers. And so that's a very key important part of the assessment. We talk about function. So typically we don't do a lot of this, but sometimes we need to if the bladder is really small. Sometimes it's by manometry or by urodynamics or by avoiding dairy. But probably the most common thing that we use is a VCUG when we're worried for looking for that function, which is where an assessment by urology becomes important. So I briefly touched upon urologic cancer. So urologic cancers are, sometimes we find it and we are dependent on you guys to help us manage these cancers. Thankfully, a lot of these cancers are not as aggressive as your pancreatic cancer or your gastric cancer, but they're still cancers. A lot of these cancers are indolent, right? And urologists manage them in a certain way. You guys do most of the management. And if you think about transplant, one of the main contraindications to transplant is active untreated malignancy. And so you could understand why we're somewhat apprehensive about transplanting some of these patients who have cancers. And so that's why it's very important that the surgeons working close consideration or close hand in glove with the urologists to make sure that we can, for those who can be monitored, we can monitor them. But for those who need surgery or some treatment, that we can get that treatment. So prostate cancer, for instance, is a perfect example of how things have changed. So, and I've been attending now for 14 years or so. And I remember when I was a fellow, and in my early career after fellowship, anybody who had prostate cancer essentially got a prostatectomy. A lot of times, however, and with the help of urology, we've shifted now. So for patients who have low-grade lesions, low PSA, we can monitor those patients. Whereas patients who have more high-grade lesions, yes, prostatectomy is the gold standard, but many of those patients can also do quite well with radiation therapy, with no wait time after the initial treatment. Renal cell cancer, again, typically low-grade, indolent, certainly not in the same arena in terms of aggressiveness as compared to like pancreas cancer. So a lot of these things can be monitored. However, a lot of times we will ask for them to be resected or at least treated, an example by ablation, because immunosuppression can cause these cancers to blossom. And sadly, sometimes we don't really have close enough monitoring of these cancers to be able to safely monitor them after. But again, in any case, any one situation, this is a conversation between the transplant program and the urologist trying to come together to create a game plan that everybody can live with. Most bladder cancers get treated with BCG or resection, depending on the stage. So, any questions there?
Dr. Cummings, I had a question. So someone, let's say they've already had their kidney transplant, and then you discover like a bladder tumor that may require or may benefit from BCG.
Yeah.
if they're on the, I forgot the last, one that was developed in 2011, the,
Gladys up?
yeah, I think there's I know there's a contraindication for EBV seropositive patients for getting that, but
Yeah.
for people, I think they treat people with latent TB before they can get that drug. So
Right.
with BCG, is that a contraindication if they're on
No,
that?
That's a good question. I'll be honest with you, I have to read up on that. But that's a good question. I'll try to get back to you on that.
Can I,
Um,
one thing, I'm sorry, do you mind if George Caso, urologist, and I do oncology with a group.
Oh, no, certainly. Go ahead. Yes, sir.
But a couple of things. Number one, BCG, as we've said, is like a relative contraindication when patients immunosuppressed.
Yeah.
But we've given it at the University of Miami. We gave it quite a bit to patients, and they actually do okay.
Yeah.
With the similar caveats. And anyway, just one comment. I'm very glad to hear that talking about small renal masses, that it's a conversation. We're finding sometimes, like I tend to see a lot of patients that come for screening and they'll have like a small renal mass or they'll have a cystic renal mass.
Yeah.
And kind of from our end, usually these are patients that are safely observed. And sometimes if they need treatment, it's almost better to transplant them up front, have the patient sort of recover their more normal physiology. And then if they require a nephrectomy afterwards, do it afterwards. And there's actually not decent, there's actually very good literature on the safety of transplanting these patients who have these small renal masses. So you're sort of seeing a shift similar to what happened with prostate cancer with these small renal masses, and even actually in some bladder cancer patients.
Yeah, and I think that's a good point. I think a lot of it honestly has to do with, again, I'm new here, but I think a lot of it has to do with history in the program, right? And some of the so every program is a little different, but I agree with you. There's certainly some patients who could be safely monitored.
Yeah.
And yeah. So taking any other questions?
I have a question.
Uh-huh.
When the patient is on immunosuppression, the high dose, would you postpone the elective surgeries? I'm asking because I had two cases last week. One had a uterus stricture on high dose of immunosuppression after the transplant. The transplant, he was doing great, but I was thinking that should I do the surgery or should I put a catheter and just postpone the surgery until he is not on immunosuppressive medications. The other one is that another patient was after the transplant on immunosuppression and came with a 5 mm stone in the ureter, and ureter in the native kidney.
Yeah. Good questions. Yeah. So, one of those graphs I showed before, we have not been able to get to tolerance, meaning most patients with kidney transplants in particular are going to be on dual therapy for the rest of their lives. Now, certainly the immunosuppression is greatest within the first 3 to 6 months or the first year, depending on how you look at it, because they get that induction therapy. But most of them are going to continue on prednisone, we try to taper off, but most of them are going to be on a combination of mifodric and tacrolimus. Definitely. What does happen over time is that we decrease the dose, but they will always be on some degree of immunosuppression. Livers are totally different because they can sometimes just be on Prograf. But so most kidney patients are going to be on immunosuppression. And I would say, as a surgeon who does on occasion non-transplant related procedures in kidney and liver patients, most patients do well. I mean, the risk of overwhelming infection is low. Certainly, there could be a little increased risk of a wound infection, but most of these patients do very well. The only drug really where we try to avoid surgery on is rapamycin, because that is known to cause horrendous wound complications. But most patients, like the things you alluded to, whether it be kidney stones in the native kidney or for our usual stricture, most of those cases can be safely done with patients on dual immunosuppression.
Thank you.
Yeah. So as it pertains to candidate selection, they go through a similar process that we talked about with the donors. They go through a process. We talk about a selection meeting, at which point, if they're deemed an appropriate candidate, they get put on the list, and then we wait for the call. When we get the call, again, it is facilitated through UNOS. Once we get a call, we call them in. We make sure there's no reason why we shouldn't proceed. So we get an X-ray, we get the EKG, we get some labs. We make sure they don't need urgent dialysis before, and if everything's okay, particularly with the cross match, then we go to the operating room. It used to be that we would do cross matches that took up to 6 hours. Nowadays, we can routinely proceed with transplant with a virtual cross match that takes about half an hour to run. So this is an example of what we do. So this is a kidney that we put on the left side. Again, in most cases, we put the kidney on the right side, but the procedure is the same. We make an incision. Either the incision can vary from surgeon to surgeon. I make a lazy S. A lot of people make a curvilinear incision. It's between the aces and the pubic tubercle. We'll go through the abdominal wall musculature. We seat the peritoneum to one side, and then we suture the renal artery and vein to the external iliac artery and vein with monofilament suture. After that, we then unclamp, we get blood supply back to the kidney, and then goes from being the color of imaginary raw chicken breast to nice and pink within a couple of seconds. We look around, make sure there's no bleeding. We insufflate the bladder, and then we do the vascular we do the connection between the ureter and the bladder. In some programs, this is routinely done by the urologist. In most cases, we call urology if we have a problem. Sometimes we have to do a UU, or sometimes we have to Soto and iliac conduit. That happens from time to time. Most of those things we do alone, but there are times when we're certainly going to need urology help if we have a difficult restoration of ureteric of the ureter to the bladder. So the standard technique is a Lynch technique, where we do after we do the vascular anastomosis, we then after we do the vascular anastomosis, we shorten the ureter, we spatulate it, and we do a running 6 or 5 PDS suture. We generally will put a stent, a JJ stent, to prevent a stricture or leak, and treat the other two if they do occur. That's taken out by you guys in the office in about 6 weeks. We then put a drain and we close up. So the actual operation takes about 2 to 4 hours depending on the situation. And then they go to the recovery room and then to the floor. So this is an example of what kidneys look like. Sorry. So you can see here, this is an example of a kidney that I procured back in Florida. This kidney had 3 arteries. So we're able to get all 3 arteries. I don't know if you can see the picture well. Maybe you can see here. This is actually the vein. This is one artery here. There are 2 other little arteries over there. But we can do those, and we can reimplant them in the recipient. This here is an example of what a kidney looks like on a pump. You can see it's in this casket that's connected to the device. Cold preservation solution is being instilled into these 3 arteries here, 1, 2, 3. It's coming out the vein, so it's an open circuit, and then the preservation solution is being rerouted back into the machine. And so you're simulating a heartbeat at low pressures, somewhere between 20 to 40 millimeters of mercury systolic, and then you're pumping the blood, you're seeing the resistance, you're seeing how much flow you're getting, and that gives you an assessment of the vasculature of the kidney and how healthy it is. And then on the left side over here, you're seeing a kidney transplant. So this is a kidney, this is the ureter before we sew it in. This is the IVC conduit that we have there. You can't really see the artery, but that's what the kidney looks like. Going from a raw chicken breast, and that's in pink. So we talked about this previously. When it's time to sew to the bladder, in most cases we do a standard Lynch technique. So we do the mucosa to mucosa layer, and then we imbricate the muscle over the anastomosis. Sometimes if we have a difficult bladder or a small bladder, sometimes we do a UU. Typically, this shows an end to end, but a lot of times you can do it side to side, particularly if they're still making urine from that kidney. And then here below, you can see what we do with the iliac conduit. We basically try to put the kidney on the right side. We sew the kidney in, and then we open the peritoneum and we suture to the conduit. At times, depending on the location of the conduit, sometimes we have to sew the kidney upside down. So, we flip it over so that the ureter is facing upwards depending on the location of the stoma. So keep that in mind when you do your iliac conduits. Think about our transplant surgeons when you're putting, depending on where you're putting it. If you put it high, we have to flip it. If you put it low, that give us some flexibility. So, and the next part of the talk, any questions about this part thus far? If you have, if there are no questions, we'll delve into the complications, and this is where we're going to run at the talk. So, complications can be sort of put into two buckets. We have technical surgical issues and non-surgical issues. So the non-surgical issues are the things like infection, rejection, malignancy, which is more common in skin long term, right? Certainly you can have some early malignancies like PTLD within the first year, but most cancers after transplant are happening many years after the transplant, mostly skin cancer. You also have things like recurrent disease, whether it be diabetes or FSGS or IgA nephropathy, right? But the main things that as surgeons we're worried about are the technical issues, right? So you have vascular problems, you have urologic problems, you have things like bleeding and thrombosis, you have urine leaks, and you have lymphocytes, and I'll go over these things. So, sort of the most feared or dreaded complication of a transplant uh, is thrombosis of the graft. So typically what you see is that you'll see patients making urine, all of a sudden stops or slowly trails off. You get a renal ultrasound and you see no flow. So this is sort of what people in our service overnight after transplant get the most worried about. This is what we as surgeons get the most phone calls about, right? Um, it is pretty common that if you do a deceased donor and they have some degree of acute tubular injury, that they will make urine early on because we give them a lot of Lasix. As an example, I typically give mannitol and about 200 milligrams of Lasix during the operation. So it's quite common for them to make 500 to 800 urine within the first 6, 8 hours after transplant, and then it trails off to nothing. That's the typical pattern um, of ATN. It also happens to be the pattern of the kidney clots. So that's why whenever we see that, we get an ultrasound to make sure, right? So obviously, if there's no arterial flow, that's pretty obvious. No vein flow can be somewhat difficult to see on an ultrasound. And sometimes the main thing that we see is no diastolic flow in the artery waveform or reversal of diastolic flow. So either of those two often prompt further intervention, most commonly going back to the operating room. So that involves if it is a true thrombosis of the vein or the artery, then we take the vessels down, we flush them with heparin, and we do the anastomosis. We make sure there's no technical problem. Obviously, sometimes we give heparin because there are times when the first time we find out that someone's hypocoagulable is when the kidney clots. A lot of these patients who are on dialysis, we know that they're hypocoagulable because they've had 3 or 4 grafts and they clot. So we know they go through a workup. Whereas a preemptive patient who's never been on dialysis who gets a transplant, sometimes the first time we find out that they are hypocoagulable is when they clot their kidney. And so that's a main problem that we have sometimes. And so when we see it, we put on heparin and we keep it moving. So, like I said, the standard of care for a situation in which you have no flow is to take them back to the operating room. But like any other field of medicine, as times go by, as we get new toys, new things, new tricks we can do, there are other options. So, for instance, angiograms. So, obviously, getting a radiologist to do an angiogram within the first 2 days can take an act of Congress to do. But there are times when it's a patient that you don't really want to operate on, they have a lot of comorbid conditions, or it's a little bit more delayed, like a week or two later, where you may get an angiogram, and sometimes you see that there's partial thrombosis. Here, this is the external iliac artery. You can see the actual anastomosis seems to be okay, but there's a clot here in the external iliac artery. So this is a paper from 2020 where they're able to show, at least in a small scale, this study had about 8 patients, where they were able to rescue these kidney allografts with these T-stents to be able to get the flow back in the external iliac artery and preserve flow to the artery. So these patients were spared having to have a reoperation, and most of them at a year had good graft function. We talked about this before. So bleeding is sort of the second most concerning thing that we can see after kidney transplant. These patients are often uremic, but sometimes it's just a technical issue. And so if you have a lot of bleeding post-op, the drain is pouring out blood, they're unstable. The best thing to do is take them back to the operating room. So you want to make sure if they're on the floor, you step them up to the ICU. If they're in the ICU, but on a step down, you step them up, you give them appropriate volume resuscitation, you get that attending out of bed, and you get the patient down to the operating room. If there is coagulopathy, which happens sometimes, sometimes they're on Coumadin, or sometimes they're on Eliquis, then you have to reverse whatever coagulopathy they may have. If it's a liver patient getting an SLK, then you have to correct the coagulopathy as well, because a suture cannot fix coagulopathic bleeding. So you make sure whatever coagulopathy you have is addressed. You make an early decisive step. Don't call it attending and being wishy-washy. If you think the patient is bleeding, the first thing you say, I think this patient is bleeding, we need to go back to the operating room. That's what we want to hear. That's what we want to know. And then you take them back to the operating room. So, and then you fix whatever you have to fix. Sometimes it's an arterial, needs a stitch. That's the most common thing that we see. Rarely does venous bleeding require a return to the operating room. It's usually something with the artery or the biopsy site, as an example, that causes us to go back. We take care of it, and then they get back on the road. In most cases, you do a quick reoperation, you fix the problem. Certainly, the discharge can be delayed by a couple of days, but those patients do very well. Urine leaks is another thing that we see. Not common. It does happen in about 2 to 6% of patients. We put stents. There's been a general shift in kidney transplant where stents were not routinely placed within the early 80s, 90s, and early 2000s, whereas most transplant centers, everybody gets a stent now to prevent a leak or a stricture. But it still occurs in about 2 to 6% of patients. Most common presentation is high drain output, and you check a drain creatinine, and the drain creatinine is 10 times more than serum. That's when you know they have a urine leak. Most urine leaks can be monitored simply by leaving the stent and the Foley catheter in, and usually within a couple of weeks, the leak seals up. Commonly it's from a technical issue, but sometimes the patient's bladder is friable, thin, they haven't made urine in 10 years, and it's a difficult anastomosis. Sometimes it's a poor preservation technique at times. Sometimes it's a lower pole artery that was missed. And if there is a lower pole artery that's supplying most of the blood supply to the ureter, and that's not reimplanted, that can increase the risk for urine leak. Other times it can be bladder injuries from sometimes you inadvertently injure another part of the bladder you didn't notice when you're doing the transplant. Sometimes it's that. Sometimes it can be the guide wire from the stent that we put in sometimes. Sometimes that can poke through the renal pelvis, and I've seen that a couple of times in my career. Other times, if it's not the early immediate post-op period, sometimes they present with falling urine output and an abdominal fluid collection or drainage from the wound. That's another one where sometimes these patients can present. Again, the primary thing you want to do is confirm the diagnosis, either by checking the drain output, or whether it be the surgical drain or an IR drain, confirm it's a urine leak. Then you want to make sure you have good source control. So Foley catheter, if they have a stent, keep the stent. If they don't have a stent, put a stent. And most times it will seal up within a couple of weeks. What is common is that sometimes we do a PCN. So we have the IR docs put a PCN tube in the kidney and drain the urine. That helps it seal up. At times we can then get a PCNUS where we get into the bladder, and that can help the leak seal up. And operative revision, I would say, is pretty rare for these situations. Sometimes if it's really early on and it's all coming out of the drain, then yes, sure. Sometimes you take them back to the operating room. But in most cases, these people making urine by the Foley, and there's much more urine coming out the Foley, so we know we can manage that in a non-surgical manner. So uterine stenosis or obstruction, like one of you mentioned earlier, is another problem that we see after transplant. Often we see a rising creatinine, and we get an ultrasound and we see this picture. So you see a dilatation of the renal calyces and the ureter and the renal pelvis. So this is hydronephrosis. So causes include ischemia. Sometimes it's scarring at the anastomosis. What kind of ischemia? Like I mentioned before, if you have two arteries, it's a lower pole artery, you don't reimplant it, that can increase the risk for urinary complications down the road. Or sometimes it's just the scarring. Everything went well, but they develop scarring. And sometimes it's a back wall suture. You let the intern sew the ureter and they bag the back wall. That's why we have to watch you guys like hawks when you're on our service. I'm probably joking there. Anyway, but anyway, technical failures can happen even we all make mistakes, so this can happen. The typical treatment is that we put a ProNF tube. A lot of times, if you think about, operative revisions for ureteric strictures used to be a lot more common. I would say, depending on where you are, it's becoming less and less common because a lot of times we can get a PCN in, and then we can have the IR docs do a PCNUS, and they can dilate those strictures, and a lot of times avoid having to have surgery. So they can, over a period of a couple of weeks, they can go from 8 to 10 to 12 French PCN tube and dilate up. Then they can cap it, make sure things are moving forward, then they can pull it back into the kidney, and then eventually take it out. So that's what a lot of people do for ureteric strictures, but there are times when you're gonna have to reoperate reimplantation for sure. So that we talked about, sorry. These are the treatment modalities we have. This is an example of what is done. Sometimes you have a kidney here, you have a distal stenosis, they're able to get a guide wire in. This case shows a JJ stent, but a lot of times they'll keep the PCN in and extend it as PCNUS. So this paper is an old study from 2016, a study from University of Michigan, in which they talk about their experience with percutaneous ureteric interventions. And in most cases, if you do it well, most of the patients are doing fine without having to have surgical intervention. This study I'm not going to talk about. It's a study showing how we can sometimes put metal stents in the ureter, that if it's sort of recalcitrant and not responding to stents in patients who you really don't want to operate on. Again, this was a small study. This was done in 2020. They only had about 10 or 12 patients. Hasn't really been done. I haven't found much data to show that this is really taking traction. But this is another option that we have. So lymphocyte is one of the few last things I'll talk about. Whenever we dissect out the artery and vein, there are lymphatics there. We do have to dissect out them to get to the blood vessels. We do tie and do the best we can. I use the ligature a lot to control these lymphatics. But lymph leaks happen in about 0.5 to 33% of patients. Most of them are not symptomatic. Sometimes it's just high drain output. In most cases, just leaving a drain will help it get better. You can confirm it by making sure it's not a urine leak, by checking the creatinine, and also by checking the lymphocyte count. And if it is, in most cases, just drainage alone takes care of it. Sometimes you have to do sclerotherapy, depending where you are. Sometimes you do antibiotics like doxycycline, and sometimes we do betadine. I will say the betadine method causes a lot of pain, is a lot worse than the doxycycline. But those can be done with sclerotherapy to help those leaks seal up faster. And so the last case scenario is a fenestration where, it's been a month or two, things are not getting better. There was a cavity, and sometimes you go in there laparoscopically and you open up that cavity into the abdomen, and that takes care of the problem. Wound complications are unavoidable. They are big incisions. The incisions, the smallest they are 5 to 6 inches, and sometimes they're up to 10 inches if the patient's obese. As we've become more liberal in who we do, it used to be that you wouldn't do a kidney in somebody with a BMI above 30. Whereas a lot of programs now, my last 2 jobs, we didn't have a BMI cutoff. We would do a kidney in a patient with a BMI of 35, 40, 45. You name it, we'll do it. If their body habitus allows us to do it. Obviously, once you start getting to about 50 and 60, then you're really running into the realm of more problems. But a lot of those patients can still be done with robotic kidney transplants. We won't talk about that today, but that's something that's being done across your country, and where we're able to transplant these patients irrespective of their BMI. What can we do? If we're still doing the old-fashioned technique, we can do drains in the subcutaneous space. We can put a Pravina, or sometimes we can just say we're not going to close the skin and put a wound back from the get-go. These are all methods that we can do to allow these patients to safely get through the transplant process and get them off dialysis. Delayed graft function we mentioned before. It's pretty rare with living donors, less than 5% of cases, but can be seen in as much as 50% of all deceased donors will need dialysis after the transplant. And I cannot impress upon you guys on our service as interns, but one of the things you may hear us talk about is not taking fluid off, because taking a lot of fluid off, causing fluctuations in their blood pressure and their volume status will all lead to prolonged delayed graft function. So whereas it might take a couple of treatments to sometimes a couple of months for that kidney to recover. And so really trying to be very cognizant about how much fluid has been taken off is very important. We mentioned belatacept before. Transition these patients from calcineurin inhibitors to belatacept in patients with delayed graft function has been shown to decrease the length of time for delayed graft function. So if you have somebody who's in DGF, the kidney was a little marginal, sometimes we may even just put them on de novo belatacept because we're expecting some DGF to help or shorten the time they're on dialysis. Typically, we also have to recognize that sometimes there's rejection and sometimes we have to do biopsies if they haven't opened up at 3 or 4 weeks. Long-term complications, we talked about rejection before. We won't spend much time there. Recurrence of disease, and this is probably, I think, one of the last 50 things I'm going to talk about, is sometimes the disease can recur. Diabetes doesn't go away entirely. Actually, some of the medications we give makes diabetes harder to control, like Prograf. And so a lot of times the disease can attack the kidney once more. FSGS, which is focal segmental glomerulosclerosis, can sometimes come back pretty rapidly. And so sometimes we have to do plasmapheresis and IVIG right after the transplant to sort of get that kidney through that process so it doesn't fail. And IgA nephropathy tends to be a much more slow-growing process. And that's something we monitor for in the post-op period, largely by the nephrologist. So some of the complications that we deal with are related to surgery, but some of the non-surgical things are actually related to the medications that we give. So Prograf, which is tacrolimus and cyclosporin, are notorious for causing hyperlipidemia or dyslipidemia and can make diabetes harder to control. There are also some patients who are not diabetic before who can become diabetic after transplant because tacrolimus is going to increase insulin resistance. So that's something we have to deal with. Malignancy, as we mentioned before, skin cancers are the most common one that we see, but lymphomas can happen too. They're typically driven by EBV, Epstein-Barr virus, and they happen sometimes within the first year. And so sometimes they present a year or two later with a lymph node that's in the neck that you see and detect and have the biopsy improve. Typically, they're treated by reduction of immunosuppression and at times rituximab, which is an anti-CD3, CD20 antibody, monoclonal antibody that can help treat those patients who have that positive antigen on those particular B cell clones. And sometimes we have to do CHOP for those who don't respond to these initial therapies. Skin cancers we talked about, the most common that we see is squamous cell and basal cell. But we also see melanomas and some Merkel cells from time to time. And I think that's it. You guys have any questions?
Thank you so much.
Thank you very much.
Right here.
All right. If you guys have any other questions, have a good day and be well. Thank you for your attention.
Thank you.